for the kind introduction. Myself, Dr. Madan, will be discussing about lumbosacral spine sonography. So where ultrasound will be helpful in neuraxial blockade especially. So for the past more than 4 to 5 decades, lumbosacral neuraxial blockades have been done based upon the landmark technique. But there are some special situations where the landmark techniques will be difficult or it will lead to failure. In those situations, ultrasound will be very much handy and it will give you an appropriate idea about where to put our needle in order to reach the neuraxial space. So those situations are, if you see in this morbidly obese patient, the spinal canal and the spinal column is completely containing the fat pad. Okay, here palpation of any bony landmark like the intercostal space as well as the spines are very difficult. So in this case, especially having this much thick pad of fat, ultrasound will be very much useful in order to identify the bony structures. Then coming to any bony abnormalities or anatomical deformities like this, where here a patient is having a scoliosis where the spine is completely curved and it will be very difficult for us to identify the exact spines as well as the midline. Okay, and imagine same patient is having this much of fat, it will be very much difficult for us to identify the central neuraxis. And one more condition is cases where the spine is completely fused. In this case, if you don't identify the window to put the needle inside to reach the spinal canal, it will be difficult for us and we will be end up in taking multiple attempts and unnecessarily giving discomfort to the patient. So here again ultrasound will give us an idea whether the neuraxial blockade can be possible or not. So we quickly revisit the anatomy of the vertebrae. So typical vertebrae consists of a vertebral body anteriorly and an arch posteriorly. The arch comprises of pedicles, superior and inferior articular process, transverse process, laminae and the spinous process. So if we take the transverse view of vertebra, it contains the vertebral body anteriorly and posteriorly the arch. Okay, and the spinal canal will be lying in between both. The posterior arch comprises of the pedicle and then the superior and inferior articular process and the transverse process and the lamina, which will unite in the midline posteriorly forming the spinous process. So coming to the lateral view, again you can see the anteriorly the vertebral body, and this joint comprises of the intervertebral disc, and one more joint is present posteriorly between the superior articular process and the inferior articular process forming the facet joint. And again we can see the spinous process lateral view, and in between is the interspinous space, and in between the lamina will be having the interlaminar space. So two spaces are there, both are in continuity only. So we will be making use of this space to enter the spinal canal and put our needle inside and achieve the epidural or intrathecal anesthesia. Coming to the lateral view, you can see the interlaminar space very clearly here. So that will be useful for to put the needle inside and reach the spinal canal. So before going into the scanning, we have to have some brief idea about the zone anatomy of the vertebra and the contents. So echogeneity wise, the bone, ligament and dura will be hyperechoic. So they reflect all the echoes hitting on them and they will appear as white. Whereas the soft tissue, mainly the muscle and the fat, will appear as hypoechoic and they will remain grey in color. And coming to the CSF, it will be anechoic as it transmits all the echoes hitting over it. And there are two other complexes which we need to keep in mind whenever we are doing lumbosacral as well as cervical and thoracic spine sonography. So these are the anterior complex and the posterior complex. As far as the anterior complex is concerned, it will be formed by the posterior border of the vertebral body, the posterior longitudinal ligament and the anterior dura. And if you can take the posterior complex, it will be formed by posterior dura, the epidural space and the ligament of Leo. Depending upon the epidural space, the distance between the dura and the ligament of Leo varies. If you take the cervical level, the space is very much small and both these two structures will remain close together and they will even form a single line also. So coming to the different views available for us to identify the central neuraxis in the lumbar region, right? We have a transverse view where the probe is kept horizontally between the intercostal line, right? Another view is the longitudinal view, where we'll be putting the probe in a longitudinal direction in a sagittal plane. Okay. Again, this view has three subdivisions, which will be the sagittal midline view, the laminar view, articular process view, and the last one is the transverse process view, which we'll be seeing further.